Thanks a lot, Benedetta, and thanks, Aurore, both for your invitation. I will provide an overview of some of the work that we have been doing the last 10 years on the development of prognostic markers for comatose patients, specifically after cardiac arrest. And as you will see, our main interest is to look at the very early phase after coma onset during the first or second day after coma onset. So the outline of this talk is roughly organized around 3 topics. The first part is on the evaluation of the preserved neural response to auditory irregularities in coma and how this relates to long-term outcome. Then I will show you some results on the prognostic value also of the resting state EEG. And then we'll also discuss briefly the time sensitivity of these prognostic markers, namely, so how do they change between the first and second day of coma, so very rapidly in this specific cohort of comatose patients after cardiac arrest. And in all these studies, we used EEG at bedside in intensive care units. So why coma after cardiac arrest? So mainly because this is one of the first cause of coma and one of the main leading admission cause in intensive care units. And it is also a specific etiology for which during the last 20 years there have been major advancement in the clinical intervention for these patients. And it is known that this medical intervention during the first days after coma onset can have a huge impact on the chance of survival. And therefore, there is a parallel need to develop reliable predictors that can tell us very early on whether these interventions are effective and whether we can personalize them to improve this long-term outcome. The data that I will show you today has been collected in Switzerland across 4 hospital sites, mainly in Lausanne and in Bern, thanks to the collaboration with Andrea Rossetti, Mauro Oddo, and Frederick Zubler, Matthias Enghi, and many other collaborators. What is the state of the art of the clinical predictors in the routine that is applied for understanding whether these patients will recover or not? So the vast majority of the clinical tests that are routinely applied are tailored towards the poor outcome, including death or chronic disorder of consciousness. To understand the meaning of this, one classic example is what is shown in this table here, where we see the results of the response to the median nerve stimulation as quantified by the somatosensory evoked response, where we see that an absence of this somatosensory evoked response is strongly indicative of a poor outcome. Instead, the presence of such a response can be present both in patients that will survive and those that will die in the long run. So this means that this test can be very specific for poor outcome, but not being very informative for patients that will recover. And this is the case for most of the tests that are routinely applied, including the identification of some specific EEG patterns, such as epileptic form features during the first days after coma onset, or the absence of brainstem reflexes, or the absence of what is called reactivity, which is the EEG response to painful stimulation. And the problem of this is the fact that it is difficult to predict patients that will survive, and many of these patients remain in the so-called gray zone, for which no actual prediction can be made, and with consequent difficulties to develop personalized intervention, and also with some possible inappropriate withdrawal of life-sustained therapy, which typically can occur within the first 72 hours for this type of patients. So there is a clear need to develop markers that can identify also a good outcome. And in the literature, in the last 20 years, there has been a strong interest to look at the neural response using EEG to auditory series, auditory regularities. And it's been proposed that the preservation of the neural response to deviant versus frequently repeated sound can be a good marker for identifying survivors. So in the classic, what is called mismatch negativity paradigm, a series of sound that is presented by repeating exactly the same tone over and over again. The regularity can be interrupted by presenting a sound that can deviate, for example, with respect to pitch or duration. And then by measuring the neural response via EEG, one can establish whether there is any discrimination at the neural level between these two patterns. Typically in a normal healthy participant, this is what we would observe looking at centrofrontal electrodes. The neural response to standard and deviant sound can start to deviate from 150 millisecond post-stimulus onset. And this is what is called the mismatch negativity component, which is with negative response when you subtract the deviant auditory evoked potential to the standard auditory evoked potential. And this is what it has been searched for also in comatose patients, looking at this very standardized stereotypical type of response. For example, in this old study by Catherine Fisher and colleague, it was reported that the presence of an N100 component, which is typically indicative of the neural response to sound per se, and a differential component, the MMN, at 150 millisecond post-stimulus onset was specific of patients who would survive. Whereas patients who were only responding to sounds without making distinction between different types of sounds were instead typical of patients with poor outcome. One caveat of this type of studies is that given the extreme heterogeneity of this neural response to sensory stimuli in these patients, typically more than 30% of patients were not included, either because they were not showing any evidence of auditory response per se, or because data was too noisy. Therefore, looking at this quite stereotypical type of response is similar to what we expect in healthy participants. This patient can disregard a large number of patients, including, therefore, affected by a large bias. Moreover, patients were also tested at variable latencies after coma onset, which can be problematic in the current standard of care, where, as I said, withdrawal of life-sustaining therapy can occur very early on within the first 72 hours. And also should mention that these studies, the majority of them, were carried out before the introduction of modern clinical intervention of these patients, which include, for example, the targeted temperature management during the first day after coma onset and sedation. So these patients during the first day have their body temperature controlled to a certain target temperature, which can range between 33 to 33 degrees, which obviously can affect these predictors and can affect the neural response to sensory stimuli. Therefore, now, almost 10 years ago, we started to reevaluate this neural response to mismatch negativity paradigm using EEG at bedside, including only patients following cardiac arrest, which were assessed using Glasgow Coma Scale and the 4-score as being in a deep unconscious state. And in these studies, we tried to control for the latencies after coma onset. So they were all systematically assessed during the first day while treated with targeted temperature management and sedated. And then the same patients were also recorded twice on the second day when body temperature was brought back to normal body temperature, and sedation was mostly excluded. And also in these patients, we assessed the outcome at 3 months based on the cerebral performance category, which is a way to stratify the outcome between 1 and 5. 1 is awakening without major consequences. 5 is death, and what is in between can range between awakening with some cognitive neurological deficits, or being not being dead but still being in a responsive wakefulness syndrome. So in these first studies, we assessed the neural response to mismatch negativity paradigm at bedside using 19 electrodes EEG system. And we included in the first study only 30 patients, 12 included as pilot cohort and 18 as validation group. And this is an example that I often show. So this is an auditory evoked potential of a patient during hypothermia. So with the body temperature lower to 33 degrees, sedated, which will not recover. So this patient will die. Yet, I hope you can see, at least qualitatively, that we can observe an auditory evoked potential in terms of modulation of the neural response to sound with respect to baseline, and also a quite clear distinction in the auditory evoked response between standard and deviant sound, very different in terms of latency to what one would observe in healthy cohort. I will show you later that these results are significant. So there is a neural correlates of auditory regularity processing, but very different what we would expect in healthy participants. So we understood quite quickly at that time that the heterogeneity of this neural response would not allow us to really isolate this mismatch negativity in terms of components. And therefore, we decided to analyze this data based on the multivariate decoding analysis at the single patient level, looking for pattern of response that could be different across patients. And in this study, we used what we called a single trial topographic EEG analysis, which in a nutshell is a way to characterize the single trial response to standard and deviant sound based on the distribution of the voltage measurement across the whole electrodes montage. So based on the spatial pattern across the whole topography elicited by the sound, and by modeling this response based on a mixture of Gaussian, which is a way to characterize the distribution of this neural response. And this type of decoding analysis allow to quantify how different is this elicited response to standard and deviant sound based on the posterior probabilities of these voltage topographies, and also to identify intervals where these topographies differ the most in the post-stimulus period. And to have an indication of whether at the neural level patients could make a distinction between standard and deviant sound, we summarized the decoding performance based on the area under the receiver characteristic curve. And so what you will see in the following is the AUC, which is this area under the curve, which tell us how strong is the difference between the response to standard and deviant sound based on this multivariate decoding. To go back to the example that I showed you before, by running this type of analysis in these specific patients, for example, we could identify that across different splits of the data, the classifier recognized and identified a discriminative period between standard and deviant auditory potential around 400 milliseconds post-stimulus onset, which we can also see here qualitatively by eye. So here is the pattern of results that we observed on the first cohort of 12 patients when we took the average of this AUC, so this decoding accuracy, across survivors and non-survivors in the first and second day after coma onset. I won't show you all the results about the significance of this AUC at the single patient level, but the idea here is to highlight that no matter what was the outcome of these patients, we could obtain on average a higher decoding performance than what is expected at chance level, which is the 0.5 AUC curve. So in fact, the strength of this decoding performance was not at all indicative of the long-term outcome. Most of these patients had significant discrimination between the two, but what we could observe instead is that it was that by taking the difference between what we had on the second day versus what we had on the first day, we observed that all patients who did not survive got worse between the first and second recording. By contrast, when we saw an improvement, this was only typical of survivors. We replicated these results in the validation of 18 patients, where you see qualitatively very similar group results of this AUC performance. And also at the single patient level, we could obtain a 100% positive predictive value, meaning that a progression, an improvement between the first and the second day of this neuro response was only present in survival. And this is a good promising test for identifying patients who will have a chance of awakening during the first and second day after coma onset, which could complement existing clinical scores, which, as I said, are mostly sensitive to patients with poor outcome. These results were validated in a larger cohort of 110 patients in total, which were recorded between 2012 and 2015 in Switzerland. We could analyze within this 110 patient 94. Within those 38 had a poor outcome. The results, again, both at the group level and at the single patient level, confirmed what we had in the first study, in which, although the vast majority of patients get worse between the first and the second day, the improvement is typical of patients who survive. Moreover, the false positive, so non-survivors that were improving between the first and the second day, were also those that typically showed some epinephrine for discharge in the EEG resting state, which is a typical marker of poor outcome, and which probably produce a confound and an artifact in the EEG for assessing the evoked activity. So by excluding these patients with this type of features, we could improve further the positive predictive value, obtain that the progression of this auditory discrimination was present in 29 of the 94 patients, within which 24 also survived, and therefore this test in this type of this validation led to a 93% positive predictive value. We ran also many tests. I won't go into details of this to see whether these results are confounded by some clinical scores or demographic characteristic by comparing survivors who increased versus those who did not increase in the auditory discrimination, and we did not find any striking evidence similar for the non-survivors. But what I think is the most interesting part is that this test indeed can be helpful in a clinical routine, because it can provide complementary information for patients that are in the so-called gray zone. The gray zone patients here are defined as patients who either did not wake up within 3 days after coma onset, having no unfavorable predictors based on existing clinical tests, or patients who had only 1 or 2 unfavorable predictors. In these 94 patients, we identified 51, so the vast majority, who had this type of features in the first 3 days. And within those, 13 had an improvement and survived at 3 months. So for 13 of these patients, this type of analysis would have been beneficial. In some of these patients, we did not only look at the outcome in terms of cerebral performance category, but we tried to better characterize how well these patients survived, running a large battery of neuropsychological tests, which was possible in 32 of the survivors. And to analyze whether this auditory predictor was also informative about the cognitive and neurological output of these patients, we split the survivors for which these neuropsychological tests were available in those who improved during the first 2 days in terms of auditory discrimination versus those who got worse. And so we could identify 14 versus 18 predicted survivors. And we compared the cognitive and neurological performance at awakening based on how well this test could predict their outcome using only the information on the first 2 days of coma, after coma onset. And what we found is that in many of these tests, indeed, there was a significant difference in terms of, for example, phonemic and semantic verbal fluency. Those who improved during the first 2 days were better than those who got worse. And also in terms of functional outcome, defined as coma duration and hospital stay duration. And another way to look at these results is to visualize the correlation of the improvement of the auditory discrimination during the first 2 days and the output at awakening in terms of phonemic and semantic verbal fluency, and also showing that this test was negatively correlated with coma duration and hospital stay duration. And these results, I would say, that are not only interesting for indeed refining the prediction of the outcome, but also are quite reassuring for excluding that this test is not trivially biased by what is called the self-fulfillment prophecy, which obviously is always present in this kind of validation, because we know that a large proportion of the bad outcome is determined by the decision of the doctors to withdraw the life-sustaining therapy in about 1/3 of the non-survivors. Although we were completely blind to the decision of what the clinicians made about the suspension of the life-sustaining therapy, the outcome itself is biased by this decision. And looking only at the characterization of the output within survivors is a further validation that this test does not only is not only influenced by the negative outcome. Okay, overall, I think these results suggest a scheme that we propose for the preservation of brain function, at least in terms of neural response to auditory irregularities in comatose patients after cardiac arrest, in which most likely during the very early hours after coma onset, no matter what is the outcome of these patients at 3 months, the neural underpinning of this activation in response to sound is preserved. And then it is the evolution over time, even over only few days, that determine whether survivors will at some point show some mismatch negativity type of response that resemble more what we know in healthy participant, while in non-survivors we would see an absence of such differential activity as a result of the degeneration over time of these neural substrates that support the activation in response to sensory stimuli. And this is, I think, is not only probably interesting for understanding that these predictive markers are very likely time sensitive, but also suggests that these comatose patients offer also a model to test more complex type of brain functions in response to, for example, language stimuli or to more complex type of auditory irregularities, especially during the first hours after coma onset, where the brain can be intact, at least at the level of the observation that we are that we can access. And also these patients are often in a deep unconscious state, so it's a strong, I would say, a very interesting model to test complex type of brain functions in patients who have most likely a largely preserved brain tissue, yet being in a deep unconscious state. With this, I would like to give a summary of this first part, so the progression of auditory discrimination in violation detection paradigm can predict awakening and also functional and cognitive outcome. Importantly, this test encouraged the maintenance of life support in case of uncertain outcome, because it's not predictive of the poor outcome. And in theory, all patients can be tested without pre-inclusion criteria and can be also made quantitative and automatic, and therefore, in principle, implementable in a clinical practice. Why I insist to say in principle? Well, because we tried, and in fact, it is still very hard to introduce a new test, which still require to administer sound and still require to have 2 recordings in a row, which the medical personnel has to add to existing clinical scores. And this is also why more recently we have tried to look at more classic type of analysis, looking at resting EEG, so without any kind of sensory stimulation. And this is what I would like to show you here briefly. In this study, we acquired data using 63 channel EEG, so higher density montage. And we included again patients acquired across 4 hospital sites on the first day of coma. This study had 138 patients after cardiac arrest. In this study, we analyzed the EEG data in the simplest, I would say, way, looking simply at the power spectra. We had access to resting EEG data that lasted between 10 and 20 minutes. And we epoched this resting EEG in intervals of 5 seconds, and then we applied very classic preprocessing analysis. And then we look at the power spectra of this EEG across the electrodes montage. We normalized also the power spectra at the level of each single patient by dividing simply by the sum of the power spectra value within the range of 1 to 20 Hertz. Here I give you an overview of the results of this power spectra in some of the patients on the first day of coma that will have a favorable outcome at 3 months. And I hope that you can appreciate here that although all of them have this classic 1/f decay, many of these survivors have a prominent peak of this power spectra in a range of frequency that can go between 5 up to even 18 Hertz, some of them with some quite typical prominent power spectra peak around 10 Hertz, which is what we expected in the normal EEG of an healthy participant. If we repeat the same exercise in non-survivors patients, we see that this 1/f decay is not accompanied most of the time by any of this peak. And therefore, not surprisingly, if we look at the group level analysis in a subset of 46 patients out of the 138, and we run a statistical test across the whole electrode montage. Here is the result of a cluster permutation statistic. We see a very prominent difference of the power spectra between 5 and 13 Hertz, with survivors having more power spectral value, higher power spectral value than non-survivors. And this result is so strong that if we average the power spectra across the electrode montage and we plot the results for the single patient, what we observe is that the survivors have all high power spectra value. If we defined a certain threshold in this power spectra as to have maximum specificity for unfavorable outcome. This is not surprising, of course, because we use exactly the same data for running the cluster permutation at group level between survivors and non-survivors, and for deriving this threshold for this prediction at the level of each single patient. But what is instead more interesting is that when we apply the same test in a separate group of patients, so 92 of them, we see that this pattern replicates very well. And indeed, in 32 of the survivors, using this very simple analysis of the power spectra, using this threshold estimated on the training, we can identify already on the first day that the patient will survive at 3 months. And if we compare what happened to the clinical scores based on other type of tests that were available in these patients on the following days after coma onset, we also see, you can see at the last row in this table, that by combining this power spectra test with the EEG reactivity, which is again this EEG response to painful stimulation, we can improve the performance by having still a very, very high positive predictive value, but also a very high accuracy and specificity. And overall, this combination gives better results than each single test that were already available. So as a intermediate summary for this study, we showed that the EEG power spectra between 5.2 and 13.2 Hertz provides maximum specificity and positive predictive value in this cohort of 138 patients. The combination of this test with reactivity yielded also some interesting accuracy and sensitivity. And here all patients can be tested, and the test is really quantitative and extremely easy to be implemented. In the next slides, I would like just to show you very briefly the results of a very recent study that is not published yet, where we take a subset of these patients that were also recorded on the second day. And this study relates to what I said at the very beginning about the temporal sensitivity of these markers. We ran on the second day of the resting state EEG, a similar analysis. And in this case, we did not observe this differential response, differential power values between survivors and non-survivors, even when we controlled for inclusion of the same patients who had the first and the second day recording. And these results are extremely, how can I say, striking, in the sense that in the first day we have a very strong effect, while on the second day recording, even including the same patients having the first day recording, this effect disappeared at the group level completely. We can see these results also at the level of the single patient. So again, this is what I already showed you for the prediction of favorable and unfavorable outcome. And these are the same patients on the second day, where you see that there is no real discrimination between the power spectra value, even at the level of the single patient. So of course, these results can be explained by many different factors. For example, certainly one is the passage of time. Other possibilities are the presence of sedation on the first day, and also the fact that on the first day, these patients are treated with targeted temperature management, which is not present on the second day. Nevertheless, I think it is important to show that some of these predictors can change in a very drastic way, even with the passage of few hours. And I think this can have some interesting clinical implication and can also inspire some clinical trial to really understand which factors can drive this difference, and therefore which are the confound that should be taken into account even on the second day or on later latencies. Okay, and this is something that I already showed, that on the first day there is a complementarity of the power spectra with the current test, while on the second day the prediction are at the chance level and there is no complementarity with reactivity or with EEG continuity. A very brief snapshot, just one figure about another recent analysis that we carried out on EEG resting state. I think Aurore asked me to present this. I'm sorry, I won't go into details for the sake of time, but I would be happy to reply to some questions if you have. So we also analyzed the spatial patterns of the cognitivity in the resting state EEG on the first day of coma. And what we showed in this study was that the favorable outcome patient tend to exhibit a structure, a modular type of connectivity, as you can see here in one exemplar patient, while unfavorable outcome patient tend to have a more uniform and homogeneous type of connectivity pattern, where connectivity here was based on the bias-weighted phase-lag index. For those of you who know this, it's one of the many ways to assess connectivity in a way that is not affected trivially by volume conduction. And also the favorable outcome patient tended to have a more variable configuration over time of this connectivity, while the unfavorable outcome patient tended to stay in one or few of these connectivity pattern. This temporal variability over time was also predictable of the long-term outcome. Finally, I would like to show you one last study. This is also not published. I think these are the best results that we have obtained in the last 10 years, at least in terms of performance for outcome prediction. These results are obtained based on EEG resting state with data acquired with this 63 channel EEG. We used 165 data from patients on the first day of coma, and we analyzed the data this time using deep learning convolutional neural network, which provides an outcome prediction, which is not just a binary score 0 or 1, but give also confidence about the level of prediction between being survivor and non-survivor. I jumped directly to the results of this analysis. This was conducted by Lucas Grua, who spent 6 months in our lab and did a very nice work. These are the results of one of the 5 split in a cross-validation analysis of the data, where you see that the survivors and non-survivors were well separated in the train and in validation, but most importantly in the test cohort, which is the independent subset of patients that was not affected by the parameter selection of the training validation set. And you see that the number of patients that are misclassified are very few. If we quantify this across the different splits of the data in the test, you see that the area on the ROC curve, the accuracy, the sensitivity, the positive predictive value, they're all extremely high, meaning that this deep learning analysis can really predict both favorable and unfavorable outcome patients, as you can also visualize here based on the ROC curve, which is also extremely stable across the splits of the data. By contrast, in patients for which we had access to the second day recording, results are still very promising, but considerably worse than on the first day. You see the misclassification gets higher in terms of absolute numbers, and you can also appreciate this by looking at the average ROC curve, which also shows a much larger variability and overall a worse and significantly worse performance on the second day than on the first day. And this is not just explained by the dropout of patients from the first to the second day, because we get extremely similar results, which I won't show you today, if we use only patients who have the two recordings, first and second day. One drawback of this type of analysis is obviously interpretability. It is indeed possible to visualize what are the weights and the information that the algorithm use to extract this informative prediction. Nevertheless, I would say that so far we didn't find a striking link and an easy interpretation of what is used by the deep learning algorithm for providing this nice score. So, for example, in these patients that will not survive, where the prediction was correct, you see that the prediction is close to 0. The weights that are used here are close to some epileptiform activity, as we expect. In patients here who will survive, where prediction is correct, the weights is more widespread, which is also understandable and interpretable. But in some other cases, this is not so obvious. For example, here in non-survivors, this is a patient that was not clearly predicted with high confidence, and the weights are also localized in time intervals which do not show any specific features, and similar in this other condition in which patients had some artifacted activity, possibly some muscle tension. The weights seems to be quite widespread over time. The only key that we could found to help the interpretation was by looking at the power spectra in these patients. So here I show you the results of the correlation between the model prediction and the normalized power spectra. Each dot is a patient. You see that for survivors on the first day, we obtained a very high correlation, significant correlation, meaning that the higher was the power spectra in this frequency band that we identified in the previous study, the higher is the chance of surviving based on the deep learning model, but not so strong for the non-survivors. By contrast, on the second day, this pattern of correlation was mostly disrupted, so there was no clear pattern, although this turns out to be significant, probably because of the number of data that we have. So overall, I hope I'm within the time limits. I showed that quantitative resting state EEG analysis is predictive of comatose patients' outcome, complements existing clinical tests, and especially so on the first day of coma. And these studies obviously leaves many open questions to be addressed. So we don't know why the first day seems to be so informative. There are many possibilities which need to be understanding for future studies. Obviously, we would like to have this test implemented also in a clinical practice. However, we don't know whether this will be possible in practical terms. And also, it would be very interesting to see whether these results can generalize to other etiologies. And with this, I would like to thank all the people, all the postdoc, PhD students, collaborators who did the work, you for your attention. And before finishing, I would like to advertise an open PhD position in our team. If you're interested in this type of research, please send me an email. I would be happy to tell you more and to send you the announcement of this open PhD position. And thank you for your attention. And I'm happy to answer your question.